Thanks for the invitation, Pierre and Tony. I will be talking today about liver transplant and related issues. And I have chosen three abstracts from this ASLD. The first one is the role of cardiac cath and percutaneous coronary intervention, which is called PCI, in preoperative assessment and management of patients prior to liver transplant. There has always and often disagreement between cardiologist and transplant team, and usually the question comes down to who would need a cardiac cath before they will get clearance. And the cardiology, they sometime and often clear the patient without cath, and transplant team often ask for a cath to be done before they get clearance for liver transplant. So this was presented by Dr. Metter from Indiana University. The background of this study is the patients over age 50 were transplanted in 2008 were about 48%. After a decade, went up to about 69%. Prevalence of metabolic syndrome continues to rise. Cardiovascular disease among liver transplant recipients is increasingly being recognized. ABLATION from 2010 in transplantation showed the 1 year mortality from cardiovascular events have gone up from 1 to 2.7%. And the optimal preoperative cardiac assessment of end-stage liver disease remain to be defined. So the guidelines from AASLD, which came in 2005, recommended stress testing in patients with high risk at age over 50, smokers, a family history of CAD, and family or history of diabetes. And CATs typically reserved for a patient in whom the stress test is positive. Now, in their center, and there are other centers who are also using their own guidelines for patient to have a cath. In their centers, they chose these risk factors: age over 60, family history, significant smoking history, diabetes, history of hypertension, prior history of CAD, and obesity. So they chose those risk factors to go for stress testing with cardiac cath, and followed by PCI if indicated. So the aim of this study to assess the contribution of cardiac cath plus minus PCI when indicated to pre-transplant cardiac risk stratification and effect on cardiovascular complications and survival post OLT. So on retrospective, reviewing retrospectively, they divided the patient into three intervals. The first one was from 2000 to 2004 when they were following the AASLD guidelines, and the last one was from 2009 to 2010 when they were using their own guidelines. And the one in between, they were in a transition phase using either of them. So asymptomatic. The indication for PCI, asymptomatic with significant disease in major vessels, or critical disease that is more than 70% stenosis in at least moderate-sized branch vessels. Number two, angiographically significant disease, which is more than 50% stenosis, associated with positive stress test, or symptom consistent with coronary ischemia like shortness of breath or chest pain. Indication for CABG bypass is a significant CAD not amenable to PCI. So what they saw was the overall mortality, a 1 year post-OLT mortality went down from 16.5 to 6.2 over the years using the first guideline, which was AASLD, and the last one, which was their own guidelines, which was more strict. The rate of myocardial infarction, a 1 year post-OLT, went down from 8.4 to 0.5%. And the cardiovascular mortality went down from 1.9 to 0.5%. Now, number of caths went up significantly from only 14% to about 68% in the last 2 years. And the PCI, the intervention, went up from 1.3 to 7.4%, which is also at least more than 5 times. So in the yellow bar, you will see the number of a cat with normal stress test. In the white bar, you will see the total number of cats with normal stress testing receiving PCI. So it has gone up also from 1 to about 5%. So the summary is overall mortality by using the more strict guidelines, doing a cat on somebody with any of those risk factors, and doing CAT in about 68% of the patients, you have mortality went down from 16.5 to 6.2. The cardiovascular mortality went down from 1.9 to 0.57. Myocardial infarction went down from 8.4 to 0.5. The CAT, number of CAT went up from 15% to about 68%, and PCI from 1.3 to 7.4. So their conclusion was aggressive approach to cardiac risk stratification with cardiac CAT followed by PCI when indicated is feasible and safe. With this approach, a decrease in mortality and cardiovascular events in the first year post-OLT was noted. Lesions requiring PCI were found despite normal stress testing. Additional analyses are underway to determine measures to use the number of normal CAT. And my take on this, that from my experience working with transplant patients for the last 6 years, yes, I think there are false negative stress testing, and many programs has their own guidelines, and some using age 65 with diabetes or history of CAD to have CAT. And sometimes cardiology do agree, sometimes they don't, and that basically is by every institution. But my take on this is you should have some sort of guidelines doing a CAT, and CAT should be done as stress test could be falsely negative on these patients. The second abstract is role of alpha-fetoprotein as an exclusion criteria for liver transplant patients in HCC meeting Milan criteria. This was presented by Dr. Hamid from San Francisco. So background is liver transplant is a potentially curative treatment for HCC. And what we are using now, most of the centers in USA using Milan criteria, which is like one lesion measuring about 2 to 5 centimeter, or 2 to 3 lesions less than 3 centimeter. They qualified for MEL exception points, and they're listed with the MEL point of 22 in most of the places. So alpha-fetoprotein has increasingly been recognized as a marker of poor prognosis. Different studies have shown a level of 300, 400, and 1,000 nanogram per ml to show the HCC recurrence, even though it's not incorporated into any of those criteria like Milan, and some places they use other criteria other than Milan, but it raised the eyebrows of the transplant team when somebody who has high alpha-fetoprotein, whether to go ahead and do a transplant or not, even if they qualify from being within Milan. So aim of the study to determine the impact of alpha-fetoprotein on HCC recurrence and the correlation between alpha-fetoprotein and explant histological markers of tumor recurrence. To determine the best cutoff of alpha-fetoprotein in predicting recurrence and serving as an exclusion criteria for LT in patients with HCC under Milan criteria. So what they did consecutive patients transplanted between 2000 to 2009 under Milan criteria, and the minimum follow-up was up to 2 years, and a patient with HCC beyond Milan or someone who was downsized in the beginning, it was out of Milan and then downsized, were excluded. So those were all strictly within Milan criteria. So 200 consecutive patients who received transplant for HCC between 2000 to 2009. Majority, 93% of them received some sort of loco-regional therapy, and median follow-up was 4.5 years with minimum of 2 years. Using Kaplan-Meier curve, the patient survival from 1 year to 5 years was 94% to 83%, and recurrence-free probability was 97, and 5 years was 90%. Now, when they look for the predictors on the univariate analysis, they found vascular invasion to be the highest predictor for the recurrence with a hazard ratio of 10 and a good p-value. And pathological stage beyond UCSF was about 4.1 hazard ratio with a good p-value. Now, to check for alpha-fetoprotein of more than 1,000, you have a hazard ratio of 4.5 with good p-value. Was more than 500 with a hazard ratio of 3.1, and more than 3 and 400 with a hazard ratio of 2.9 with p-value of just borderline, maybe because of number of patients they have in that category. Now, on modality analysis, they saw vascular invasion as a predictor as only predictor for a HCC recurrence with the hazard ratio of 4.5 with a good p-value. Now, when they look at the association between alpha-fetoprotein and vascular invasion, higher the alpha-fetoprotein, the higher chances that one would have vascular invasion. With alpha-fetoprotein more than 1,000, the odd ratio of 6.8 as compared to alpha-fetoprotein more than 300, and on that more than 300, the odd ratio was 4.1 with a good p-value all the way. So their conclusion was alpha-fetoprotein more than 1,000 nanogram per ml best predict the vascular invasion with the odd ratio of 6.8, and post-transplant HCC recurrence in patient with ACC meeting Milan. Applying alpha-fetoprotein cutoff of more than 1,000 would have resulted in exclusion of 4.7% of the patient, but would have decreased the recurrence by 20%. So my take on this is that we should incorporate alpha-fetoprotein into our criteria, and especially somebody who has high alpha-fetoprotein and not coming down after loco-regional treatment. We should be careful listing them for transplant because the recurrence rate has been shown from different studies to be high as compared to normal alpha-fetoprotein. Now, cutoff is different to have a cutoff level. They have been studies showing 300 with the higher risk, but definitely something over 1,000 we should be careful transplanting them. So the also conclusion was consideration should be made to incorporate alpha-fetoprotein as an additional selection criteria for liver transplant in patients with HCC to improve the outcome. So my third abstract is sirolimus-based immunosuppression is associated with improved sustained virological response to antiviral treatment for patients with recurrent hep C. This was presented by Dr. Astana from University of Alberta. Recently, there have been studies going on sirolimus and post-transplant recurrent hep C and HCC. There have been interest shown sirolimus as a anti-HCV agent or work to enhance the interferon-based treatment and achieving the higher SVR, and then also has a effect on tumor and anti-tumor activity. So that has been those two things have been addressed recently in the last few years. So impact of calcineurin inhibitors has been addressed in the past and studied, but data on the sirolimus is still lacking. Now, sirolimus-based immunosuppressive did not significantly affect the timing of and severity of HCV recurrence. That was shown by the same author and published this earlier this year. And McKenna showed that sirolimus as an independent predictor for minimal fibrosis at 1 and 2 years post-OLT. So aim of the study is to assess the impact of sirolimus on antiviral response post-OLT and determine the effect of SVR on the patient survival. So intention to treat analysis included 100 patients who commenced treatment between 2002 to 2010, and they analyzed the outcome of those patients. And sirolimus was considered to be a primary immunosuppressant for patients with both sirolimus and calcineurin inhibitors. So out of those 140 were on sirolimus, 35 Prograf, 24 cyclosporin, and one of them was on mycophenolate. And the overall SVR was 47%, with sirolimus had a 60% SVR, tacrolimus 43%, and cyclosporin 29%. On Univar analysis, the factor impacting SVR was sirolimus immunosuppressant with odd ratio of 2.4, female sex with odd ratio of 2.9, and non-genotype 1 with odd ratio of 2.76. Now, on multivariate analysis, only non-genotype 1 infection significantly influenced the SVR with the odd ratio of 2.66 and a good p-value. Now, per protocol analysis of patient who finished treatment, that was 64 out of 100, sirolimus base was the only factor that affected the SVR. Now, 36% or 36 patients did stop treatment. We don't have a data why they stopped treatment, and from the prior studies, we have known that about 30% of the patients on sirolimus, they do interrupt or stop treatment because of surgical procedures, wound infection, and delay healing of the wound. A patient with SVR has significantly improved survival than non-SVR. Sirolimus, however, did not impact patient survival. So this was a patient who achieved SVR, and we all know, and most of us do know, that SVR is associated with improved outcomes. So this is not something which is new. Basically, if you have SVR, you will have better outcome. So sirolimus is associated with significantly higher SVR rates following antiviral recurrent HCV post-transplant. Achieving SVR was associated with improved post-treatment survival. So my intake on this, I probably will not use sirolimus just for hep C yet until we have more data to show that intention to analysis has shown that the SVR is better on those patients. So for now, I will not be using anybody with hep C recurrence in prevention or treatment for HCV and sirolimus, basically.
Thank you, Tony. Thank you for moderating this. I also would like to thank Pierre Golem and Dr. Carey for doing this for the 10th year. It has been a wonderful event, and it keeps increasing in its popularity. I was asked today to talk about liver cancer, and when I skimmed through the abstract, there was close to 200 abstracts or more, and it was really a decision to make whether I speak only of 3-4 abstracts that I think they are the most important, or try to put a theme and come up with a message. And I felt strongly the latter option would be better, so I took away some of the basic science stuff, focused on the clinical abstracts, and this is what I would like to present to you. The question I asked myself first is, are we making a difference in hepatocellular carcinoma management? And as you know, every year, 700,000 people around the world die from liver cancer. It's an amazing number of people. It's actually the second most common cancer death cause in the world, and yet it's equal to the incidence of the disease. So the same number of people come down with liver cancer each year. With that in mind, that's about 1,900 patients die each day. So whatever modality we are offering stands short of solving global problem. However, if you look at this first abstract 266, which came to us from Japan, they tried to see if there was any improvement in the survival of patients with hepatocellular carcinoma in the Japanese population over 30 years. They looked at 148,000 patients or more, and this is what happened over the period of 30 years. between 1978 and 1980, the survival for 5 years was no more than 5%. In the year 2000, the survival was close to 35% or more, and the last period of time that they tested for was between 2001 and 2005, and the 5-year survival is about 43%. So we can really all be proud that we have improved significantly the survival rate, but we have a lot of work to be done. So the question then is, what are we treating hepatocellular carcinoma? What patterns of treatment? What struck me is there are so many trials. These trials tend to be small and tend to be each specific to a specific institution. However, the BRIDGES study, which is multinational study, tried to understand the pattern of treatment across the globe. In this cohort of patients in abstract 267 by Roberts focused mainly on the North American population, and in that they actually wanted to see what pattern of treatment for hepatocellular carcinoma has been applied to 1,605 patients, majority of them from the United States. About 200 of them were from Canada. Those patients, interestingly, the cause of their cirrhosis was hepatitis C in 45%, hepatitis B in 27%, alcoholic liver disease in 24%, and NASH in 12%. Others counted for 18%. 13% of them only received liver transplant, and 85% of that population received some type of locoregional treatment. That included resection in 29%, RFA or alcohol injection in 31%, TACE in 57%, and radiotherapy in 4%. 20% received some systemic treatment, and the majority of the time, 91% of the time, it was sorafenib. So the question should be asked, what is the treatment for what lesions? And without going through many algorithms, I decided to go through some abstracts and compare some modalities of treatment for specific subpopulation of hepatocellular carcinoma. In this study from China that came to us, it's authored by Quan Shang and associates, basically they tried to compare the efficacy of radiofrequency ablation to resections in lesions that are less than 2 and less than 4 centimeters. And if you look at the survival over 1, 2, and 3 years, it was almost identical. And they concluded from that that RFA is an acceptable modality for that subpopulation of hepatocellular carcinoma. However, we are immediately reminded by another abstract that came from Korea that while locoregional treatment might be good, it is associated with significant recurrence rate. And in this study that compared transarterial chemoembolization and RFA, which is abstract 2261 from Chung Associates in South Korea, you can see that the risk of recurrence from in patients who underwent TACE at year 1, 3, and 5 was twice that of the risk of recurrence from RFA. They tried to address then the question, if you're going to use RFA as your first modality of treatment, to what extent you can stabilize the disease and how long you can keep using RFA. We tend, if the lesion recurs, send the patient and give him additional RFA. And this study from Japan that was in late-breaking session, number 30, basically came down to remind us that the 3-3 rules is what they really advocate, and simply said they advise that in over a 3-year period, for lesions which are 3 centimeters and less than 3 in numbers, you should not go beyond 3 trials using RFA. Otherwise, you should shift to a different modality if they recur beyond that. So if your patient is being stabilized, whether you are bridging and waiting for liver transplant, or whether this is definitive treatment, and after 3 trials over a period of 3 years, they have additional recurrence, actually it's futile to keep doing it beyond that point. This study, which is came from Florida, tried to address the question whether all TACE is the same. And as you know, there are two main methods of applying transarterial embolization. One is that of conventional treatment. The other is using beads therapy. And the eluding beads are becoming more popular. And in this study, the interesting thing about it is the fact that total response and the complete response rate was very similar, whether you use the conventional therapy or the drug-eluding beads. However, if you look at the last line, that's rather impressive. And what you see there is that after 15 years, in those who were treated with drug-eluding beads, 40% were still alive, after 15 months, while in the patients who received conventional TACE, only 8% were alive. There really no explanation based on the population in these two. They were very matched very well, and there was no explanation by the author why that difference was there. But there was a clear evidence of difference in survival between the two populations in the two methods. It seems from all the abstracts that RFA is being pushed more and more toward first-line therapy. So you should ask the question, how safe is RFA? The answer to that comes from abstract number 2273, which is also from South Korea by Parks and Associate. If you look at this abstract, you realize that mortality rate is rather very low, 0.39%. The complication rate is about 6.9%. The majority of these complications, however, are minor complications in 5.1%, mainly post-RFA syndrome, and only 1.8% of these patients had serious complications that ranged as listed from liver abscess to intraperitoneal bleed, liver failure, variceal bleed, cholecystitis, hemothorax, and small bowel perforation. So trying to put this all together, Canello and Salab from the Imperial College in London tried to do a meta-analysis to decide what treatment is best for hepatocellular carcinoma. And in abstract 2204, they looked at a period of time between 2005 and 2009. They reviewed about 135 randomized controlled studies. Interestingly, they only found 25 studies that met their criteria of inclusion. Out of those, when they ranked these studies according to their strength, the studies came down to 17. And I think that's why these algorithms sometimes are so difficult, because really there's no large uniform study that came up with the best algorithm for treatment of hepatocellular carcinoma. However, based on their meta-analysis, they concluded that the evidence-based conclusions regarding treatment of hepatocellular carcinoma suggest that RFA should be the first line of therapy for lesions below 3 centimeters, that careful selection is crucial in sending patients to transarterial chemoembolizations, both for recurrence purposes and because there's higher incidence of liver failure in these patients, and if systemic therapy is to be used, then sorafenib is your drug. I want to move on a little bit to talk about surveillance. And I think God gave us only one liver. And because of that, we have to be careful what we do with it. In this abstract that basically came from Canada, they tried to look at what is the most important thing in trying to identify hepatocellular carcinoma early enough, and what's the impact of etiology and screening in hepatocellular carcinoma. They looked at 3,064 patients. They were probable cirrhotics. To confirm their clinical criteria, they biopsied about 2,442 of them, so these were biopsy-proven out of the 3,000, but they analyzed all the 3,000. And hepatitis C, which was discovered by screening, which was done in a period of 6 months, every 6 months or less, measured 2.37 centimeter. When you went beyond the 6-month period, your lesion was bigger than 2.5, which is a crucial number. It was a 3.37. So this was one of the studies that demonstrated that delaying the interval of screening results in a growth of tumor that might impact both the prognosis and the outcome of the tumor. Actually, if you do screen every 12 months, then the size of the tumor discovered averaged about 3.67 centimeter. In their population, it was interesting to see that the 8-year incidence of hepatocellular carcinoma depended on the cause, something we know, but once verified. So in viral hepatitis, the 8-year incidence of hepatocellular carcinoma was 32.8%, while in autoimmune hepatitis, the incidence was only 3.3%. These are cirrhotic patients with autoimmune liver disease. I think that's a very important finding. It might have implication how often do you screen your population with their sub-stratified risk. In alcohol and NASH population, the incidence was very similar to the viral population, about 27.3%. In all other causes, was much less than that. Does it make a difference where you come from and how aware are you about your liver disease? It does, and actually even if you live in the United States, certain pockets might differ. And this study comes to us from California Central Valley. It's a study number 2274 and looked at the survival of patients with hepatocellular carcinoma compared to the SEER data in California in general, not the national SEER data. This came from Alta and Associate from University of California, San Francisco, UCSF Fresno compound. They looked at 160 patients, and only 5.1 of them received potentially curable therapy. That include transplant, resection, or RFA. 60% of that population did not receive any therapy whatsoever. And the population was 49% Hispanic, 12% Asian, 6% African American, and the study, in their opinion, reflected there's lack of awareness of chronic liver disease in certain population, and there's lack of access to hepatologists and screening methods. The survival is also and the surveillance issue was addressed in another nice study that came from University of Illinois that tried to stratify these patients, understand what difference does it make, where they come from, what the difference between the surveillance population and the non-surveillance population. So in this study, 2175, the abstract basically entitled Survival with Hepatocellular Carcinoma is associated with surveillance lesion size, ablation, and transplant in an area with limited availability of transplant from Kalowitz and Associate. They looked at 167 patients and analyzed them retrospectively. They found that basically if you do surveillance at a period of 6 months or less, you are 81% likely to meet Milan criteria than non-surveillance patients who met the Milan criteria only 35% of the time. For those, just a reminder, meeting Milan criteria is crucial for receiving any of the treatment, including liver transplant. So having a tumor less than 5 centimeters, less than 3 tumors is essential to make sure that patients can be transplanted. If you compare the two populations, those who were undergoing regular surveillance, 23% received transplant compared to 4% who did not go regular surveillance. It goes on to compare the care between the specialist and primary care. It was far more likely, actually 57% compared to 13% for patients who are being cared by specialists to receive regular surveillance. It's still not ideal, but it's also a call to action by the primary care to make sure that surveillance takes place. And the treatment with RFA was 16 to 3%. Some 3 other abstracts also address the issue of surveillance, which I really wanted to focus on today. A study from Italy suggested that the main cause of screening failure was interval than more than 6 months. This came from Treviglio Hospital in Italy. Then there's abstract 224, which was a Moroccan study that looked at the Moroccan population over 15 years period, and the improved prognosis during that time was directly correlated with 35% increase in surveillance rate. And finally, another study that addressed that was a study from Georgetown that showed that patients who go through surveillance definitely have an earlier stage disease. I think the point was made very clear during this year ASLD, the importance of screening for these lesions make a difference in their outcome and the size of the lesion that's detected. I asked myself the question, if we have 700,000 patients who are dying every year, how can we cure them all with transplant when the total number of transplants since it was introduced by Tom Starzl did not exceed 110,000 over worldwide? The answer, obviously, transplant, while it's wonderful for certain population and it made a difference, and so does RFA, we need something more. In the last ASLD and the one before that, Italian group was commissioned by the European Union to actually study how you can target the hepatocellular carcinoma cells by certain viruses that can damage the hepatocellular carcinoma within attacking the DNA by implanting basically a destructive necrotizing inducing genome in it. And it reminded me of what that movie that Bruce Willis basically was star of, which the premise of is that he was the only survival from a virus that was invented for the single purpose of curing cancer. But this is good story. It's not bad story like it is in I Am Legend. In a phase 2 randomized controlled trial, a virus called JX594 it is a virus that is a targeted multi-mechanistic oncolytic poxvirus in patients with advanced HCC. The final data was published. And in this study, it's shown that JX594 is as I mentioned, a first-class targeted oncolytic poxvirus, which is designed to selectively induce both oncolysis, and in addition to that, it can target the tumor and cause vascular shutdown and anti-tumoral immunity to be stimulated. 30 patients were enrolled in this study. They were previously treated for hepatocellular carcinoma, and these were failure of treatment. So these are patients basically who really had no other hope but this drug. And they were randomized to either high dose of the virus or low dose of the virus. The virus was given intramurally every 2 weeks for 3 doses. They compared the median overall survival between the high dose and the low dose, and it was 13.8 for the high dose and 6.7 months for the low dose. While these numbers look low, remember these are patients who failed even sorafenib, which we really was the treatment of choice for these patients. 54% exhibited necrosis of the tumor, and because of that, they concluded that this is a very promising therapy. With that, I'll conclude with my presentation, and thank you very much, and happy holidays.
This is a man that I saw just about 10 days ago, and we're still working this one through. So he's 51 years old, and he's a commercial pilot, and he recently received a letter from the FAA grounding him. And he wants your help. He'd like you to write a letter on his behalf saying it's okay to fly. So in March of 2010, he was just having a, in between flights, had a beer with a couple of friends in Puerto Rico and developed hematemesis. And as it turned out, he had cirrhosis. He had esophageal varices. They were treated, banded, and he's on a non-cardioselective beta blocker. He's never had clinical encephalopathy. He's never had ascites, even when he was resuscitated from his bleeding. He's never had edema. And his liver tests were remarkably okay. Trivial elevation of bilirubin and INR. Child Pew score is A5. MELD score is 12. He's had a full workup, and no etiology for his liver disease has become apparent. He steadfastly denies a lot of alcohol intake. I guess we have to wonder a little bit about that. His past medical history is positive for a myeloproliferative disorder, not requiring treatment. It's very clear based on vascular ultrasonography that he does not have portal vein thrombosis as a cause for his varices. In fact, the CT scan shows findings typical for cirrhosis. He also has a very little bit of elevation of his ammonia level, and this is an ammonia level done now when he's not bleeding, but when he was in the hospital closer to his bleed, he had similar elevations of his ammonia level. Yeah, now what are we going to do? Dr. Mullen, I wonder if we could use this as a segue to how do we manage our patients with cirrhosis who may or may not have elevated ammonia levels with or without clinical encephalopathy?
The ammonia, I don't think contributes anything to this because your ammonia level is going to be up if you have cirrhosis, and it doesn't necessarily relate to whether you have hepatic encephalopathy or not. In fact, whether you have hepatic encephalopathy or not is based on your clinical exam, which we know in this patient is normal. So he doesn't have hepatic encephalopathy, and we don't have any evidence that he is minimal because we haven't tested for it. So the real question is, are you going to do minimal and open up a can of worms, or are you not? Would that be true?
It's exactly the quandary, yes.
Yes. Certainly, I don't like the idea of people up in the air flying above me who might be out of control. But it's nearly as bad on the road.
Would it be okay if you sat alongside him in his airplane?
Sorry, Bill, what'd you say?
Would it be okay if you sat alongside him in his airplane while he's flying you somewhere?
Well, I mean, if I was out of flying myself, I wouldn't mind. I could take over if he was having trouble. But to be honest with you, the way you present the case, maybe it's how I see it. This patient doesn't worry me too much, because he doesn't have any history of any previous problems at all. And what you're really pushing at here is, should we test him for minimal? And if he has minimal, then restrict him. And my answer to that is, I think probably not. But you could disagree with me.
We don't have a lot of people with exactly this problem, but we have a lot of people who have maybe minimal encephalopathy and they're still driving a car. So if we could sort of go from this sort of esoteric case to the more bread and butter everyday thing, what are we to do with patients who may have minimal encephalopathy who would still like to drive their car?
Well, I think we'd all agree, someone with overt encephalopathy, we don't want them on the road because you don't know when it's going to come back. If you have a person, and remember, by definition, minimal, they don't have any symptoms. Okay, they're not supposed to have symptoms of CNS disturbance. So if they have none, and you test them, and they have, by whatever criteria you use, a minimal HE, then we know that these people are associated with more car accidents. I'm not aware of people, flying planes into the ground, but certainly more car accidents are likely to occur to these people. So some people argue that these patients' driving license should be taken away. There isn't any great legal way of doing that, but some people would argue that. Now, a lot of people are very quick to say, take the car away, but I don't think it's quite so straightforward as that. For instance, I think what should happen is if you have an abnormal psychometric test, in other words, you have minimal HE, then someone should test your driving skills. So you should have a pretty strict driving test. And if that expert says you're not able to drive, then that's the end of that. For a car, I don't know how they do it for the plane, but they have obviously people who do the equivalent in a plane. So I think it shouldn't be you get minimal HE criteria and then you lose your license. You should be minimal criteria, or minimal HE criteria should lead to very intense testing of your driving ability. Would at least be one thing I'd like to see happen.
You've implied but haven't quite stated that you think we don't have a legal requirement to report these people to the motor vehicle department. Is that?
Well, I don't think anyone even bothers to find out what the law is, but in most states there's no requirement to do this. Yes, absolutely. And remember, we're bad judges of driving capacity. We're probably pretty good at picking up overt HE, though, so I think that's not unreasonable.
So Kevin, just to clarify, so if somebody has overt HE and is treated with pharmacological therapy and is in a prolonged remission, say 3 months later, has not been hospitalized, has not had bouts of HE, you would tell that patient that they should not drive indefinitely.
If that patient wanted to get back on the road again, because I presume they were taken off it originally, I think they need to have formal driving tests, done, not just psychometric tests.
I see.
The psychometric test generally will get better when you get treatment. The question is your driving capacity satisfactory, can be resolved by a proper driving tester? Doctors are not driving testers.
So
We're
since-
just people who might know when people could be under the weather or not able to drive properly, and we would recommend with someone with an overt attack not get back on the road again until someone confirms they're driving okay.
So this comes to mind because I'm faced with this situation right now. I have a patient who had overt HE, who was treated, it was in the hospital, has not had any bouts of HE in over 4 months, now wants to drive again. So as you stated, we're not good judges of driving ability. How do we resolve this? Is there any practical
Well,
way?
rehab services in most hospitals, major rehab services, have the ability, or a bunch of people who assess driving ability. They have simulator cars. They could go start with that and then get out on the road formally and do it in a bigger way. But I think that's the way to do it. By the way, it's not easy to get people to follow the instructions, though.
I think this is a real challenging question. The analogy with seizure disorders are that if you remain free of seizures under therapy, then, and it's, I don't know if it's 6 months or a year, then you are then free to drive. And with HE of the nature that I think that Pierre's talking about, a chronic, potentially relapsing disorder, metabolically controlled, but can be relieved by appropriate therapy, why would you not, maybe you did, but why would you not say if he's been successfully treated for 3 months or 6 months, or we can discuss whatever time, that at that point you show you can control the condition?
Well, that's what I'm saying, but I think it would be good to have someone formally verify that the person was okay for driving, because doctors are not very good at figuring that out.
Well, the
They
driving
can just
test
say
is
he's not
no
having
use either, is
encephalopathy.
it? I mean, the driving
You've
test
taken him
doesn't-
off the road because he can't drive or may not be able to drive, and you want him to go back on the road, you probably should test him and see can he drive. The practicality of that is another issue. But there are most rehab hospitals with serious rehab will have a whole group of people just dealing with that issue alone. And they can verify or get this person
But don't
verified to
your
be okay to go back
sophisticated-
on the road.
Don't your sophisticated tests for testing subclinical HE, can they not pick up those deficiencies? Coordination deficiencies in
In a
particular.
German study, the psychometric test performance didn't correlate with driving capacity. Certainly in Virginia, it has. So you're right, Tony, you could use it as a surrogate. But I still think society would probably want more stringent testing. But at this point, we're winging it. We don't really have rules like this, It's just, it comes up all the time, and Bill asked me these tough questions, but I'm not sure we really have the answers. But we're not very good judges of driving ability, I can tell you that.
I would just like to remind the audience that there is a website there is a webcast available on our website of a discussion about driving and minimal encephalopathy with Dr. Mullen and one of the attorneys from the Cleveland Clinic talking about our legal responsibilities and the evidence that surrounds us. So with that, I think we need to move on to the next case.
So the next case is, I think, relevant to broad practice, relevant probably to issues beyond liver disease, but certainly to liver disease too. So this is someone I chose to call Cheetos Man. So he's a 61-year-old male with hepatitis C-induced cirrhosis who was listed as a candidate for transplant about 2 years ago. He has a MELD of 9, which basically means he has very good synthetic function, and his weight, at least in the state of Ohio or anywhere else in the country, would probably be indefinite for transplant. He had a history of variceal bleeding, which is how he was diagnosed with cirrhosis, and ended up getting banded and then had eradication of his varices, and this was 3 years ago. And he really hasn't had problems with that since then. So he basically has recurrent ascites, despite the fact that his synthetic function is not very poor. We see this, unfortunately, not infrequently, patients who have good liver enzymes, but a lot of portal hypertension. and he requires 6 to 8 liters of, in the form of a large volume paracentesis removed every other week. He has mild lower extremity edema. He gains about 6 kilos per week, and he returns to clinic asking to be tapped. Again, a common theme that we see in our clinics. Patients show up distended, uncomfortable, want to be tapped. He thinks he may need to be tapped weekly from now on. So he is on furosemide 80 milligrams twice daily and spironolactone 150 and 100 AM and PM, so a fairly reasonable dose of diuretics. He reports strict adherence to a 2-gram sodium diet. And he's seen a dietitian twice, and he says he does not see the point of that visit or of doing that again. So on exam, he's icteric. He has a slight icterus. The medical assistant observes him dumping a sizable bag of Cheetos on the way into the exam room. Although his fingers still tell the story. He's got bulging flanks and shifting dullness and 1+ lower edema. He has an ultrasound which shows cirrhosis, but not much else, no portal vein obstruction. And his labs are, as you can see them there, fairly typical for cirrhosis. So the next point is, what do we do with this patient? What next steps would you choose to see if you can improve his what appears to be diuretic refractory ascites?
Take away his Cheetos.
Take away his Cheetos. Okay. He says he doesn't eat them that often. So, right. So reinforcing dietary compliance. I guess we could do that. Any other practical considerations aside from this? Is there any way to prove that he's eating a lot of Cheetos or not eating a lot of Cheetos? Get a spot urine for sodium and potassium, and then the results will. Okay. Specific gravity?
Just to tease this out a little bit more, when I tell my residents to get a urine sodium, they say, wait a second, he's on diuretics. You can't get any value out of urine sodium concentration if they're on diuretics. Isn't that right?
Well, that's right. In a different context. It's not right in the context of someone who's fluid overloaded. You actually want them to be on diuretics in order for the test to be relevant. So in the interest of time, maybe we can move to the next slide. So first of all, does diuretic therapy work for patients who have cirrhosis and ascites? The answer is overwhelmingly yes. 90% of patients who are compliant with a 2-gram sodium diet and take their diuretics as prescribed have resolution of their ascites on therapy. There is no doubt in anybody's mind about that. There is a subset of patients who have true diuretic resistant ascites, and those patients obviously don't respond. But in general, anytime somebody requires this frequency and this volume of paracentesis, you have to be wary of the fact that they may not be compliant with diuretics. And these are the guidelines from the International Ascites Club, which is a group of really smart people who are interested in ascites, who come up with recommendations. And this basically breaks down how high a dose of spironolactone and Lasix you can go up to before declaring the patient diuretic resistant. And you will typically see a decline in weight of about 300 to 500 grams per day if the patient does not have peripheral edema, and higher than that if they do. That's typically the result you would expect with treatment. So, as I mentioned before, when he is questioned further, he says that he does indulge in a bag of Cheetos from time to time. The family doesn't seem to be terribly, and it doesn't endorse him in a very strong way. They seem to think that he's not compliant. And then he gets a spot urinary sodium and potassium done, and these are the results. What do those results tell us?
Non-compliant.
I'm sorry?
He's non-compliant.
He's not compliant. Why is he?
The sodium should be lower than potassium in somebody who's compliant.
Right. So the sodium is typically lower than the potassium as a spot value in someone who is adherent to a 2-gram sodium diet. So that's one easy way of giving you some ammunition to get up in his face and tell him that he's not. No, I'm not suggesting that you do that. I used to do that, and that actually backfires all the time. I don't think you should confront the patient with their dietary indiscretion. I think you should tell them that based on the result, it does not appear that they're being compliant with the diet, as opposed to being confrontational about it.
So what would you have expected the urine sodium to be if you really had refractory ascites?
So for a spot urinary sodium, it's a little difficult. But if we go to the next slide and show what a 24-hour urine. No, so the next slide actually shows you how much sodium there is in Cheetos. So a serving has about 290 milligrams of sodium. So if you consume a large bag, which typically has anywhere between 6 to 10 servings, you've pretty much wiped out your sodium allocation for the day. So it's important to teach patients to read the nutrition facts that are on every food item at the supermarket or anywhere else, and actually count not only the amount of sodium that they're consuming per serving, but also the number of servings. That's often a thing that patients don't pay attention to. Next. So to answer Dr. Kerry's question, so if you do a 24-hour urinary sodium, and if that value of your urinary sodium exceeds 88 millimoles per liter, then you're basically exceeding your 2-gram sodium diet. And consequently, you can actually use the amount of weight gained in a 24-hour period of time to calculate how much sodium the patient is actually consuming. So a 2-gram NaCl diet per day is about 88 millimoles. If the patient is gaining a kilo per day, let's assume, and if you actually calculate their sodium intake based on this formula, it translates into 228 millimoles. So that's almost 2.5 times what they should, or close to 3 times what they should be, the amount of sodium they should be consuming. Or as Dr. Ashfaq pointed out, you can just measure a spot urinary sodium and potassium, and if the sodium is greater than the potassium, then there's a 90% likelihood that the patient is exceeding their dietary allocation of sodium. Go ahead.
Was congestive heart failure ruled out, maybe ischemic coronary or cardiac arrhythmia, diminished function?
Yeah, they were ruled out because this patient's listed for transplant. So bad heart failure, we typically don't list for transplant. That's pretty much this case. So one last point I'd like to make, which is I think important, is every time you do paracentesis, for every liter you remove the equivalent of about 130 millimoles of sodium. That's about a day's. So if you remove 6 liters, you remove about 10 days worth of sodium in a diet. And if you remove more than that, you're basically, in fact, removing the total salt load of that patient for that period of time, assuming they're not excreting any sodium. So even if they had no kidney function, they should not build up that much ascites over a 10-day period of time. So if someone is requiring a 10-liter LVP every 7 days, it's almost by definition that they're actually exceeding their sodium.
About doing early tips in those patients, we used to all do all what you are saying. You manipulate diuretics a lot, you do this and that. But now there's more and more data suggest that actually you may gain survival benefit, whatever, with early tips as opposed to wait until you optimize everything else. And
Right. No, I'm not going to talk about it because this is only a focus on diet. So no, I'm not going to talk. So basically, this patient improves his dietary compliance and eventually requires less paracentesis and does not require tips. So there, I mentioned it. Okay. And that's pretty much the case.
So why don't we move to the next and last actually exercise of the morning, now afternoon. But before we do that, I think it's important that we recognize there were an awful lot of people who made this meeting possible and made it successful. And thanks to all of these people.
Sure. Thanks for your time.